We are going live in 5, 4, 3, 2, 1. We are live now.
Good evening, everyone. We are again here with another masterclass in hand surgery. Today's topic is distal radioulnar joint issues. And on behalf of Rajasthan Orthopedic Surgeons Association, I welcome you all in this masterclass. Today we have a galaxy of faculties from Pune, Dr. Binu, from Vellore, Dr. Binu Thomas, and from Nashik, Dr. Amit. And we have many faculties from ROSA also. So not taking much of the time, I would like to invite the ROSA President, Dr. Kishore Raichandani, to formally initiate the proceedings of today's masterclass webinar. Over to you, Dr. Kishore, sir.
Good evening, Dr. Rahul. Thank you very much for giving me the opportunity. You, Dr. Opportunity every month. Dr. Purnima Patni. Welcome to Dr. Thomas from CMC Vellore and Dr. Amit from Nashik, apart from the ROSA faculties. And I would like that we should start as early as possible without wasting any time. Such a great topic, the DRUJ, which is so complicated and so difficult to understand. And we will get to know a lot of things about DRUJ. Thank you. Thank you very much.
Thank you, sir.
Over to Dr. Amit.
Yeah. So thank you, sir. So apart from the national and local faculties, today we are having with us Dr. Purnima Patni ma'am, who is the president of Jaipur Hand Surgery Society. Or today's moderator is Dr. Amit Vyas. I'd like to hand over mic to Dr. Amit Vyas, who will formally introduce the faculties, the guest faculties and ROSA faculties, and start the proceedings of today's webinar. Over to you, Amit.
Thank you, sir. So good evening, everyone. Today we are here to discuss about the distal radioulnar joint problems. And these problems are frequently encountered in our orthopedic practice. And there are variability of treatments available and various treatment modalities are there. So to draw a conclusion that how to tackle these problems, ROSA official asked me to conduct this masterclass. So first of all, I would like to welcome all of you for this masterclass. For this, we have invited our renowned faculty. First of them is Dr. Binu P. Thomas, sir. Sir is senior professor and head of the department at the Department of Hand Surgery at CMC Vellore. And one peculiar thing about him that CMC Vellore is the first institute in the India where the MCS in hand surgery was started, and it was his great efforts of Dr. Binu Thomas sir that it was started. And sir is renowned faculty, and he has given more than 100 talks and invited lectures all over India and at international level also. And he has more than 50 papers published in international and national journals. And he has awarded renowned awards like Dr. Baxi Award and a lot of best paper awards also. And he has written a lot of book chapters, and you will be surprised. Today topic, distal radioulnar joint chapter is also written by him in the book textbook of orthopedics of Kulkarni, textbook of orthopedics. So I welcome Dr. Binu Thomas sir for this webinar. And I had great opportunity to interact with him when Dr. Jaswant Singh sir was the secretary, and he recommended me from the ROSA, and I visited sir as a visiting fellow at CMC Vellore. Then our second faculty is Dr. Amit Varade. He's senior consultant at Sopan Hospital, and he owns his hospital also, and he's quite renowned wrist surgeon all over India, and he has published about 10 papers in various national and international journals, and he has presented a lot of papers in national and international conferences. And fortunately, I worked. We did fellowship together at Ganga Hospital, and he's trained with Dr. Binu Thomas sir also, at CMC Vellore. So welcome, Dr. Amit Varade, for this. With this, we have our ROSA president, Dr. Kishore Raichandani sir. He is senior professor at SN Medical College, Jaipur. He is unit head at Department of Orthopedics at SN Medical College, Jaipur, and he was also head of the department. And Dr. Jaswant Singh sir, he is senior consultant at Kota. He runs his own hospital and he is renowned orthopedic surgeon. And Dr. Rahul Katta sir, he is honorary secretary of ROSA. He owns his hospital, Katta Hospital at Jaipur. And Dr. Purnima Patni madam, he is teacher and mentor of all hand surgeon at Jaipur, and he is retired professor and head Department of Orthopedics, SMS Medical College, Jaipur. Currently, he works in Surya Hospital, Jaipur. And with this, we have Dr. Ramesh Vijay sir. He is senior consultant at Jaipur, and he runs his own hospital. Dr. SN Soni sir, he is quite senior orthopedic surgeon, more than 30 years of experience. He owns his hospital, Chandni Hospital at Kota. Welcome, sir. And with this, Dr. Narender Saini, he is associate professor at hand surgery unit at SMS Medical College, Jaipur. And Dr. Deepak Jain, he works at Mittal Hospital, Ajmer. He is senior consultant, and his main area of interest is joint replacement and foot and ankle surgery. And he's quite academically active in ROSA. Welcome, sir. And Dr. Ali Hasan, he is senior consultant at Sikar, and welcome, Dr. Ali Hasan, sir. So with this, I welcome you all, and we'll start the proceeding of this webinar. First of all, I will invite Dr. Binu Thomas, sir. He will deliver a lecture on distal radioulnar joint. Then Dr. Amit Varade and Dr. Deepak Jain and me, we will present the cases, and then we'll discuss and interact about the DRUJ problem. So first of all, I will invite Dr. Binu Thomas, sir. Sir, please share your screen.
Sorry to interrupt you. Just one information. At present, there are 3,200 viewers live on OrthoTV. Sir, please. Thomas, sir, please.
This speaks volume of the success of the our program.
Am I visible now?
Yeah, sir, you're visible. Can
Fully?
you come out? Because I think something is either magnified or...
Magnified now?
No, it's okay, sir. Now it's
Correct?
yes.
Okay. Thank you very much for this invitation. Greetings from CMC Vellore. I really thank Dr. Amit Vyas ROSA and all the faculty and office bearers and the members for giving me this opportunity to speak today. And also to OrthoTV for spreading this across India and probably the world. So, as Sir mentioned, it is a complicated topic. So I do hope I'll be able to shed some light to this area. I have nothing to declare. So the distal radioulnar joint injuries are not uncommon, and these can be isolated soft tissue injuries or also associated with fractures. It is interesting to note that 40% of the TFCC tears are associated with distal radius fractures. Excuse me. And these eventually lead to a painful arthritis, these injuries. Here you see a spectrum of injuries that can affect the distal radioulnar joint, like a Galeazzi fracture and old childhood injury and pure soft tissue instabilities and others. So to start with a few words on the anatomy. The distal radioulnar joint has got bony and soft tissue stabilizers. The bony stabilizers are, as you all know, the sigmoid fossa of the radius and the distal ulnar. So it is interesting to note that the diameter of the ulna is quite, it's about 25% less than that of the diameter of the radius. So there is some amount of translation also occurring during this time when you have movement at the distal radioulnar joint. Now, there's been some studies, especially by Amit Tolat, about the type of the distal radioulnar joint, especially the sigmoid notch. In his anatomical study, he found that there's a flap-faced type of sigmoid notch, which actually is very unstable. And these injuries happen to these type of sigmoids much more commonly than the others. Similarly, again, there is a joint that is actually the sigmoid and the ulnar head are parallel to each other. That is the type 1, or it can be oblique, which is called type 2. And there is a reverse oblique type, that is the type 3. So these are the different types of distal radioulnar joints according to Tolat classification. Coming to the soft tissue stabilizers, this picture is taken from Turek, in which I wrote a chapter. And this is the soft tissue stabilizers are the triangular fibrocartilage, the radio-ulnar ligaments, the ulno-lunate and the ulno-triquetral ligaments, as you can see here, and the subsheath of the extensor carpi ulnaris and the ulnar collateral ligament. Here's a dissection by my friend Makoto Tamai, who shows excellent ligaments of the distal radioulnar joint by very good dissection. And this is the dorsal radiocarpal ligament, the ulnostyloid, as you can see marked here. And that's the distal dorsal radioulnar ligament and the ulnar collateral ligament seen on this view. Now, coming from a carpal perspective, you can see that the triangular fibrocartilage consists of superficial and deep layers. The superficial layers are attached to the styloid process, while the deep layer, also called the ligamentum subcruendum, is attached to the fovea. This is the foveal insertion. And this is very important clinically. That's you can see the superficial and the deep insertions in this dissection picture. Now, coming to the function of the distal radioulnar joint, all of us know that the distal radioulnar joint has got, importantly, supination and pronation happens through that. But that's not all. It is a primary weight-bearing joint, really, as according to Louis Schecker. And this is how the distal radioulnar joint functions as a weight-bearing joint. You can see through the ulna, it supports the radius. And that's what the major problem with distal radial joint pathology is, problems of lifting weights. Now, this is an interesting concept as suggested by Haggard. He says the key to DRUJ stability is a term called, he uses a term called tensegrity. This is a continuous shift in tension and compression of the deep and superficial portions of the ligaments and constitutes the core of DRUJ stability. And this is the essence of what he calls tensegrity. The type of injuries can be simplified into instability, which can include the soft tissues. Instability also can be because of incongruity of the bony parts, and the instability and incongruity can lead to an arthritis at a later stage, and or instability and incongruity with arthritis. So this is to sum up the problems that can occur in a distal radial joint. So this is the soft tissue disruptions, as I mentioned before, and bony disruptions or incongruity. How do distal radial joint injuries present? This is not in an acute setting, but in a chronic injury, it presents as swelling and tenderness over the distal radial joint. The ulnar-sided wrist pain, or USWP, as commonly in a hand surgery parlance, is called on loading the hand and on pronation and supination. That's the hallmark. Again, you may get clicking, and classically there will be inability to lift weights. The examination is always done by the patient seated, examiner in front, and with the elbows on the table. So most importantly, when you examine the joint, you look for focal tenderness, especially in these areas that are marked. The number 3 is the head of the ulna. And number 4 is the fovea, between the extensor carpi ulnaris tendon and the flexor carpi ulnaris tendon, or the volar aspect of the distal ulna. So tenderness in the fovea suggests a foveal tear of the triangular fibrocartilage. That point. Now, when you start, the first test you elicit is the DRUJ impingement sign by putting the wrist in forced ulnar deviation. The forearm is pronated and supinated. A positive test just means pain, and it means there is an ulnar-sided pathology. The next one is testing for stability, the ballotment test. Ballotment test, you just move the radius up and down. The examiner moves it, and always check it in different positions of the forearm, supination, pronation, and neutral, and compare with the opposite side also. So a soft endpoint suggests a severe soft tissue disruption with a much more increased movement. Similarly, the piano key test is when you see the distal ulna more prominent dorsally, and you press it down and it jumps up. So that is the piano key test, and it suggests the ulnar head instability. One thing I have to always mention is it is not the ulna that subluxates, it's actually the radius. The ulna remains straight and the radius is the one really subluxate, though we always say ulnar dislocation or ulnar subluxation. Now the other test is the grind test, or the ulnocarpal stress test. Again, you just press the rotate the ulnar deviated wrist and look for any pain. A press test is when the patient, a seated patient, has to push himself off a chair with the wrist, using the wrist on the table. Or you can say use the screwdriver maneuver, just like we use a screwdriver. All these produces pain and suggest a DRUJ pathology. Coming to the investigations, X-rays, the basic investigations. Whenever you take an X-ray of the wrist, you call it a PA view and not an AP view. You want a PA view. And a true PA and a lateral view are mandatory to assess the distal radial joint. How will you know what is a true PA view? So for that, here you can see that blue arrow points to the groove for the extensor carpi ulnaris tendon. And that, when you see that radial to the ulnar styloid, you know it's a true PA view. And on a lateral view, you see the silhouette of the pisiform between that of the volar rim of the capitate and the volar rim of the scaphoid. So then this is a true lateral view also. And only on these views can you look for shifting of the ulnar head to assess any dislocation or subluxation. Shecker uses a weighted lateral view. It takes about 12 pounds of weight. The patient holds a dumbbell and an X-ray is taken and look for any dorsal ulnar subluxation. That's a good test. It's a dynamic test. The other test we use a computer tomography. You compare both the wrists, and here you can see there is a definite dislocation with a fracture on the affected DRUJ, ulnar head also. Or you can use this 60-degree resisted pronation view where you can see the difference in there is a subluxation of the ulnar head again. So look for these subtle signs. How do you clinically identify on a CT? There are a number of ways. This is a common method, the radioulnar line method. Whenever you see that the displacement of the ulna is more than 25%, you call it a definite subluxation. So that is the Binu et al.'s radioulnar line method. So look for this in the CT scan. Other investigations, now everybody does MRIs. MRI, a 3 Tesla MRI gives an excellent look at the joint. And you can see where even the avulsion of the radial TFCC tear is very commonly seen here. I mean, is seen here where the yellow arrow is pointing. And you can also do an MR arthrogram, which we don't commonly do, but that if there is any passage of the dye from the radiocarpal to the distal radioulnar joint, it means that the ligament is ruptured. The TFCC is injured. Arthroscopy is the gold standard in diagnosis. Classically, the trampoline test and the hook test will be done. I think Dr. Amit is going to discuss more of the arthroscopy or show us more of the arthroscopy today. And coming to the classification of the triangular fibrocartilaginous complex injuries, the original classification of Andrew Palmer, he divided it into a central perforation, which is the 1A. The 1B is what we generally are clinically interested in, the foveal avulsion injuries. Then 1C, the ulno-lunate and ulno-triquetral ligament injuries, which are rarely seen, and radial avulsions of the TFCC insertion. So the management can be non-operative initially. We always initially manage it non-operatively by putting an above elbow cast, 4 weeks, followed by this kind of splinting, the so-called Bauer splint. It prevents supination pronation, and then of course modification of activity. Then you also do the non-steroidal injection, anti-inflammatory and steroid injections if the pain persists. But if the pain is continuing, then we plan for usually surgical management, especially if there is instability. You can, once there is a definite sign of an avulsion of the TFCC, we go for either arthroscopic or an open repair or debridement of the ligament. So on arthroscopy, if the central tears are seen, they are not amenable for repair, so we just debride it around. But the peripheral tears can be repaired. Usually we do a capsular insertion of the 1C and 1D and foveal insertion for the foveal tears of TFCC. So there is a classification by Atsai where he divides this into different types of injuries where there is injury to the superficial and the deep ligaments. And based on that, the management varies. If it's a stable injury, immobilize. If it is, again, just the superficial ligament, you repair. And if it is, if there is associated instability, then you will have to do a foveal fixation of the triangular fibrocartilage. Again, more severe injuries, TFCC repair, again, either arthroscopic or open. And if it is the joint is very unstable and the ligaments will not heal, which is usually any injury after 3 or sometimes even 6 months, we will not be able to repair it. And then you do a reconstruction by a number of procedures, which I'll talk. And if there is arthritis, you go for a DRUJ salvage. Now, this is the technique of open repair. There are dorsal and volar approaches. The dorsal approach, the classic approach is by Mar Garcia Elias. You go through the 5th extensor compartment and expose the distal radioulnar joint and the triangular fibrocartilage. Now, recently I came across this paper, and from then on I changed from dorsal approach to volar approach for the triangular fibrocartilaginous complex, and it seems to be much simpler and less damaging. So I use it now. This is the technique I use. This is one of our colleagues who had a distal radioulnar joint laxity injury with a TFCC foveal aversion. Presented 3 months since the injury, and she had a volar approach and fixed the TFCC. This is the follow-up. He's got excellent range of motion. Similarly, that was open. Then arthroscopic TFCC, again, this is what we do. We go through the 3-4 portal with the probe in the 4-5 and the 6R portal. That's the hook test. We are hooking to see there is a foveal avulsion. So that confirms the foveal avulsion. And then the arthroscopic technique is used. Usually, what I do is a transosseous suture. That we make drill holes from the ulna into the ulnar head, and then repair the triangular fibrocartilage, the triangular fibrocartilage to the fovea by these pull-out sutures. And this is one of the patients we did, and that's the post-op results. Very good range of movement and stable elbow. Now, the treatment algorithm for acute ligamentous instability is this. Whenever we try volar close reduction if it is subluxed, and if it is reducible and stable, go for immobilization. If it is irreducible, then look for causes of irreducibility. Usually it's a interposed extensor tendon that can be retrieved and joint reduced and the TFCC repaired, or close pinning can also be done. This is the acute ligamentous instability. This is the management algorithm. Now, many times instability is associated with fractures such as this. Everybody knows distal radius fractures, Galliaci and styloid fractures. So there are some pointers on the X-ray to suggest a DRUJ instability. That is shortening of less than 5 millimeters, more than 5 millimeters relative to the ulna styloid base fractures, which are displaced more than 2 millimeters. So whenever you see these on the X-rays, you make sure that the DRUJ is examined, and if unstable, appropriate treatment is done. Then widening of the DRUJ interval and dislocation on the lateral view. So these are the signs you look for in a distal radius fracture. Intraoperatively, after fixing the ulna, we always test for gross instability. Look for instability. In fact, preoperatively, if you check on the other side, you may have an assessment of how unstable the ulna is. And if it is unstable, generally we do a KY fixation. Now with Galliaci fracture, usually they are stable. The DRUJ instability becomes stable once the radius is well fixed. There are some indicators of instability, especially when the distal radius fracture is less than 7.5 centimeters from the joint line. And look again, as I said, with instability, try to stabilize with a K wire. Nowadays, we prefer 2 K wires rather than a single wire. Coming to the ulnar styloid fracture, it is seen along with 60% of distal radius fractures and can maybe fractures of the tip of the styloid or including the base where the foveal insertion is there. If grossly unstable, we always fix it with various techniques like a tension band wire, as you can see on this X-ray. Now, this is a controversial part. Is an ulnar styloid to be fixed following a fixation of distal radius fracture? So 76 out of 138 distal radius fractures, they found ulnar styloid fracture. Finally, Kim et al. Came to the conclusion that it doesn't really matter. Though this is not what we clinically feel, and we always try to fix the ulnar styloid. The other fracture involving the distal radial joint is an ulnar head fracture. Look for it very carefully. It's an inherently unstable injury, and the fractures are through the sigmoid articulation. A CT scan is very useful, and it can be fixed. This is here. This ulnar head fracture was fixed with just 2 screws and with a very good improvement in motion. And another one is a sigmoid notch fracture. Again, you need a CT to really identify the fracture well. Here we have used 2 screws. The other option is a distal radius plate. Now, when the distal radial joint is chronically unstable, it's a very debilitating condition, presents us with all those clinical features I mentioned before, and again can be due to a bony or a soft tissue problem. The chronic distal radial joint instabilities, when they are ligamentous, what do you do? So, if the sigmoid fossa is competent, then there are many operations, soft tissue operations, which are done, like the radioulnar tether using a free graft, or an extensor retinaculum can be used to plicate the ligament and make it stable, or the classic operation, the Bryan Adams procedure, which is reconstruction of both the volar and the dorsal radioulnar ligaments. Now, this is the classic radioulnar tether procedure. We don't use it nowadays, but it is there in literature, where you put a tendon graft like a palmaris longus or a facial after, and tether the ulnar to the radius, thereby making it stable. Extensor retinaculum procedures are also described, especially by Ravi Gupta, which is a good procedure and uses the retinaculum to reconstruct the ligament. What classically everybody does nowadays is the Adams-Berger procedure, the reconstruction of dorsal and volar radioulnar ligament using a tendon graft with 2 tunnels, as you can see, a radial and a ulnar tunnel. There it is. This is the diagrammatic representation where the tendon grafts reconstruct both the dorsal and the volar radioulnar ligaments through this procedure. Here's a patient, again, a physician, developed chronic instability, and you can see the frankly unstable. This we preoperatively, that was a view you can see again. The ulnar head sublux dorsally. It was treated by the Adams-Berger procedure. That's the tendon being tunneled through the radial drill holes and then brought out through the ulnar and tied together. And that is the joint is after suturing. You can see that. And this is post-operatively 5 years, good stability of the joint. So examined. Okay. Another operation which is very commonly done, especially when you do like a Dirac procedure where you excise the ulna, is a Green Jupiter, where you use FCU and ECU tendons to anchor the distal end of the ulna so that it becomes stable. Now, whenever the distal radial joint instability is associated with fractures, such as a malunited distal radius fracture, Jupiter said any residual angulation more than 20 to 30 degrees is associated with a pathologic risk biomechanics, and restoring DRUJ congruity decides the outcome of a corrective osteotomy for DRF malunion. So that's a very important statement by Del Clock in 2012. So here's a 28-year-old male. He was injured 10 years ago and comes with now an unstable elbow, which he needed, and a deformed wrist. He needed it corrected. So here we just did a corrective osteotomy and used a volar plate with a iliac bone graft and got the distal radius and the radioulnar articulation in place. So that's a post-op function, very good improvement in the deformity and also range of motion. Now, the unusual case, a 12-year-old boy who had a both bones forearm fracture, 8 months duration. That was his pre-op pictures. And that's the X-ray. So here, what we did in order to avoid the physis from fusing, we used KVAS. And we did a corrective osteotomy with a bone graft proximal to the physis, as well as an ulnar shortening with a tension band technique. So he went on to good healing and correction of the deformity with good range of motion. What happens when there is arthritis associated with instability or incongruity? Usually the supination and pronation are painful and with or without instability in these situations. Like here you can see there is a definite arthritis in the distal radioulnar joint articulation. Clinically, it is characterized by crepitus. So always, whenever the patient comes late, look for this crepitus. Crepitus is an important hallmark of arthritis, even if sometimes radiographically it may not be seen. So management of, like for any arthritis, the surgical management is either of these: excise, fuse, or replace. So let's see what we can do. So the salvage option is the excisions, the distal ulnar resection arthroplasties. It's very popular. We all know about it, the DRUJ and its variants. When David Green came to Vellore, we said DRUJ and he was very upset. He said it's pronounced Dara. So the CH is silent. And so DRUJ and its variants. Or you can think about fusions, the DRUJ fusion and proximal pseudarthrosis, the popular Sauvé-Kapandji techniques. Again, there are two techniques which we don't use: the DRUJ fusions or the one bone forearm procedures, and the replacement arthroplasty. Replacement arthroplasty because we still have not come across these joints at home. So resection arthroplasty of the distal radioulnar joint can be total when the whole head of the ulna is removed. It is popularized by Dara in 1912. Described and popularized. Or partial excision of the head by Herbert. Or we can also partially excise the head of the ulna and with a tendon interposition. In these situations, the TFCCs are generally intact. So it's more for an arthritic problem rather than for a instability, these two operations, the partial resection and interposition. The question is, in a DRUJ procedure, how much ulna is to be resected? Is it a subperiosteal excision or an extraperiosteal excision? And how to manage painful instability of the distal ulna after the excision? So these are questions that are always asked whenever people discuss the DRUJ procedure. So a number of modifications have been described where the ulnar styloid is left behind and extraperiosteal and subperiosteal resections are done. The original DRUJ, which was described in 1912 and later in 36, he kept the ulnar styloid, he left behind the ulnar styloid and went for a subperiosteal excision also. Then Garcia Elias did a study to find out how much ulna needs to be excised. According to his study, he found that only this B and C is where the ulna is actually articulating, and you remove the 27 millimeters, up to 27 millimeters of ulna can be safely removed in a successful DRUJ procedure. Here's a patient who had a non-union with avian, painful crepitus of DRUJ. This was following a post-revascularization. And here what we did was the distal radius was ununited, very unusual case. Here we did a wrist fusion and excised the distal ulna so that he could get supination and pronation. So that is his post-op. He was very happy with his stable, painless wrist with a reasonable supination and pronation. Coming to the Bowers procedure or the hemi-resection interposition technique. It's generally not used in trauma, usually for rheumatoid arthritis, where, as I mentioned before, The triangular fibrocartilage is intact. So the joint is reasonably stable in these positions. So you remove the articulating part of the ulnar head and put a tendon interposition. So here's a patient who had a good range of motion following a 1-year follow-up of Bauer's procedure. The very famous Sauvé-Kappanji operation is actually an amalgamation of 3 different procedures. And it is an amalgamation of the names of 2 surgeons. So the procedures used in here are distal ulnar excision, DRUJ fusion, and proximal pseudarthrosis combined. And this is a X-ray of a good Sauvé-Kappanji procedure. It preserves the ulnar support of the carpus and the ulnocarpal ligaments. So, as I mentioned, the ulnocarpal ligaments create a buttress that prevents ulnar translocation of the carpus, thus improving radiocarpal stability. Here's a 28-year-old lady, neglected childhood injury, and now very painful. So we did a Sauvé-Kappanji, but used the resected ulna as a graft to provide that breadth of the joint. And she has done quite well, good range of motion. She was very happy again. Now, there is a problem with distal ulnar excisions or the DRA procedures, especially in the Western literature. You see with this condition, radioulnar impingement syndrome. It's a painful instability following excision. And it is classically characterized by a short ulna proximal to the sigmoid notch with a scalloping on the radial distal radius, as you can see where the arrow is pointing, and convergence of the radius and the ulna. A number of procedures have been described. If at all patients complain, which we don't see very much in India, I don't know, maybe our patients have more pain tolerance. We generally use the Sai-Stilwell or the Breen-Jupiter procedure, where a FCU loop is taken and threaded through the ulna, like in this case. What about the long-term results of DRA procedure? Stern published good long-term results. So he said, even though patients had radioulnar impingement on dynamic X-rays, they were not associated with pain clinically. Here you can see the impingement. Now, coming to this question, should we do Sauvé-Kappanji or DRA? Usually, in clinical situations, we are always concerned. So they looked at, this group looked at 85 patients who had DRA and 57 patients who had the Sauvé, a total of 85 patients, 57 had DRA, 28 had Sauvé-Kappanji. They found there were no significant differences in the range of motion, function scores, etc. And so they did not find any difference between the two. But literature says DRA is done for older, low-demand patients, Sauvé-Kappanji for younger, active patients, and Bauer's procedure when the TFCC is intact. This one-bomb procedure is there in literature. We don't use this because it restricts supination and pronation, but it has been found to be a good salvage procedure. Coming to the implant arthroplasties, this is for completion, implant arthroplasties. There have been hemiarthroplasties, like a partial ulna or a total ulna, and the Shekhar total DRUJ arthroplasty. So here is a patient, courtesy of Louis Shekhar, under whom I did fellowship when he had, kind of perfected this prosthesis. And so I had the opportunity to assist him for these cases. So it was a construction walker with a painful wrist and instability with arthritis. So this is his prosthesis. It's a semi-constrained DRUJ arthroplasty, where this ball, which is attached to the ulna, rotates in the radial, the plate. So that's the prosthesis, and this patient had very good recovery and good results. However, the early studies showed a 5-year survival rate of 96% for the Shekhar prosthesis, but there have been recent articles saying the complication rates are much higher on a long-term follow-up. So what does literature suggest about DRUJ salvage? There was a good paper by Jesse Jupiter. So he summarized the instability. Whenever you have instability, salvage, bony procedures such as osteotomy can be done, or a soft tissue procedure such as an Adam Burger. When arthritis intervenes in a younger patient with a TFCC intact, you do a Bowers procedure. Whenever the TFCC is disrupted, a Sauvé-Kapandji is done. In the elderly patient, you do a Dirac procedure. And what happens when you have multiple failed procedures? A partial arthroplasty, multiple failed procedures, poor soft tissue. Then you do the total DRUJ, Shecker arthroplasty. Or a single bone forearm if none of these works. So to summarize, clinical features suggesting DRUJ instability must be carefully looked for in the presence of associated fractures. X-rays are important. True P and lateral views must be taken. Additional imaging such as CT scans, MRIs must be done. And arthroscopy is the gold standard in diagnosis of ligamentous injuries. And appropriate treatment must be provided for the type of problem. So thank you very much for the younger orthopedic surgeons. If you are interested to take up hand surgery, there is a MCH program with a 3-year course, post-MS, and we have 3 seats. Entry is via NEET. Thank you very much for this opportunity.
Thank you, sir, for the excellent talk. We are really benefited with your talk, sir. And certainly we will have some questions. So, first of all, I would like to ask one question. Sir, as you shown your talk, the Bowers splint. So, we are using above elbow slab to prevent rotations. So how it works, how it is helpful, can you describe?
Yes, now, the Bowers splint is only used after 6 weeks of immobilization. So it just restricts supination, pronation after the 6 weeks of above elbow casting, which is standard. So you actually, after healing, when you allow the patient to mobilize gently, you want to prevent the supination, pronation. Patient should not overdo it during the final period of healing. That is what the Bowers splint is being used for.
Okay, sir, thank you. Any other faculty?
Molded thermoplastic splint, which, that's a picture I've taken, but this is a molded thermoplastic splint.
Okay, sir, thank you. Can we use sugar tongue type of splints in initial phase?
You can use. I don't think there's anything wrong with that.
Mm-hmm.
Except that, sometimes that they tend to become a little loose. So, but sugar tongue splints can be used. Many people actually do that.
Yes. So, yes, sir. Soni, sir.
One question.
Yes, sir.
Excellent talk, Dr. Thomas, sir.
Thank you.
It was really a great pleasure to have you here. My question was, in situations like when you fix distal radius fracture, and after fixation of everything, when you find that this ulnar head is dislocated, in that situation, would you try to reduce it and fix it, or acute situation, you'd think for the later reconstruction when complete dislocation is there?
That's a very good question, sir. Now, following trauma, if there is and once you fix the distal radius correctly, normally the ulnar should have reduced. So if you still have the ulnar dislocated, then there are only 2 options. One is your fixation is not good enough.
Okay.
There have been some mistake in your fixation. But if that is not there, then you look for irreducibility of the ulna. That is usually the extensor carpi ulnaris or one of the flexor carpi ulnaris may be interposed and that is preventing the reduction. So in both these situations, you have to relook at your fixation and you have to look for any interposition of these tendons, or sometimes even the capsule or one of these soft tissues can be interposed. So they have to be removed primarily itself. You cannot keep a dislocated ulna there, and that's the thing. That's what I would do.
So in first instance, you would like to fix it with the radioulnar K wire, or you would go for reconstruction later stage?
No.
If everything is fine, if the fracture reduction is good,
I would only fix it with a radioulnar wire. We don't primarily go and repair the TFCC. So in fact, in my experience, most of the patients actually do well with those radioulnar wires, and they become a stable joint. So that literature also suggests that. Very rarely do we do this acute, scopy and reconstruction of the TFCC.
Thank you, sir. Thank you very much.
I would like to ask one question, Amit.
Yes, Amit.
Yeah, sir. What do you do during Dirac's procedure? Do you keep the ulnar styloid, tip of the ulnar styloid over there? And what is your post-surgery protocol?
Yeah. So normally we excise the ulnar styloid also, but it's a subperiosteal excision so that the soft tissue envelope is still there, and we put the patient in a cast for 3 weeks, and then we start mobilizing. So that is what our protocol is.
And in your practice, sir, how many times you came across a complication of impingement, and how you did?
That's what I was saying. Our Indian patients, our pain tolerance must be much better, because we don't generally see it. I don't know if our senior people have also this experience. So I have done in 3 patients, if I can remember, this the Sai Stilwell procedure in India. I mean, both of them were all 3 of them were when I had excised a giant cell tumor of the distal ulna, where the ulna was actually, though it's not a real classic Dara, but where the ulna was quite unstable, and so I did that. Now, but while I was training in the US, there were so many patients who complained following a Dirac procedure that they had pain, especially on weight bearing. Like this patient whom I showed, Shekhar's patient, I was there when this was being done. So that patient had very great difficulty in doing his routine work. I mean, they do gardening as weekend jobs even if they may be blue-collar workers. So they find it very difficult. And this guy actually, his follow-up, there was a picture, I don't have it with me. He was lifting a wheelbarrow up following the Shekhar prosthesis. So there in the Western society, I think Dirac gives much more problems than we actually see clinically.
Okay. Thank you, sir.
Well,
but one more thing I forgot to mention. My friend Dr. Sudhir Warrior had shared one of his cases with me. I didn't show it here. He has a very nice technique where he punches up some fascia lata and puts it between the radius and ulna, and it acts as a cushion. So he sutures the fascia lata to the head of the ulna so that it acts as a cushion, and that kind of reduces the pain.
Modified Bowers.
The modified Bowers without the head. Yes.
I have followed a few cases where green Jupiter procedure was done by someone else, and I felt that it becomes more painful. Have you experienced the same?
That's a good question. I mean, in my experience, there was no further pain and all, but I feel that these are also procedures which may not completely take away the radioulnar impingement. There has been, some, still there will be some impingement, but it's a dynamic procedure really, where these muscles also contract and keep the ulna a little away from the radius, so thereby limiting the pain. I'm not saying it's completely painless, but it limits the pain, these procedures. So this is where, this kind of situations are when, they do the Shecker prosthesis. So there have been modifications of Shecker where you can do it with a longer stem, so that even if there is a distal ulnar excision, you can still do it. Yes, sir.
So normally the distal radius fractures that are treated conservatively, there is some collapse in old age patient with osteoporosis, and there is always some prominence of the ulnar styloid and some deviation and restriction of supination and pronation. So what should be done in those situations?
Generally, we don't touch anything, touch this for 6 months. And in my experience, most of the patients, especially the elderly, they
adjust.
They become much better, or they adjust.
Yes.
But if it is very painful, there are two options. One is an ulnar shortening osteotomy to bring the joint back in place.
Yes.
Again, the other option is a wafer resection. If the impingement is onto the, the triquetrum, like that. So the ulnar shortening osteotomy also aligns the radius and the ulna, and maybe taking away the area where there is a painful arthritis or loss of cartilage. So these are options that are available. But generally in an older age group, give it time, wait for it, and then, patients generally don't ask for any surgical correction. That's what.
Sir,
Anybody else has suggestions on this, the other faculty?
Yes, sir. In clinical practice, yes, sir. Thomas, sir.
Yes, sir.
We are delighted to have you in this ROSA meeting. This is our pleasure, and this is an honor for all of us. And we have heard a lot about you. So in clinical practice, we have seen that many of the fractures of the lower end of radius, where this DRUJ looks like overriding or some subluxation, where 1 or 2 millimeters of subluxation is there or overriding is there. Within 6 months or a year of time, the pain goes away, and mostly they are not having so much complaints.
Yeah.
The complaints are there especially in the younger age group, whereas in the elderly or middle age group, the complaints goes away as the time passes. What's your experience for that?
That has been my experience also, sir. And thank you for your kind words. Anyway, that has been my experience also. The elderly usually don't require much of procedures. The younger patients do have problems. So that's where you consider a wafer resection or a ulnar shortening osteotomy to take away the area of injury, to change the articulation, basically.
Sir, I would like to add in this. As you told that only infrequently they are symptomatic, these type of problems. And as you mentioned in your talk also that painful crepitus is good sign to see that some arthritic changes are developing or not in chronic cases. But means the problem, it may be because of that I have not done a lot of reconstructive procedure like ulnar shortening or something. So usually my inclination is towards the arthrodesis, salvage procedure. So can you limit that at which duration you will go for a salvage procedure, and up to which limit you will do some reconstructive procedure to save the DRUJ?
So when you're talking about arthrodesis, Amit, you're meaning the Sovek Kapanji.
Yes.
Or is it?
Yes, yes.
Yeah, the Sovek Kapanji. So, if the joint is salvageable, that is, you don't see any major cartilage damage, then I wouldn't go for a arthrodesis at all. I would try the shortening osteotomy or the wafer resection. And especially in a younger patient, we don't want unnecessarily. See, even a Sovek Kapanji has a problem that the distal ulna is still mobile. Even in a Sovek Kapanji, you can still get the radioulnar impingement. So it is not, totally trouble-free and pain-free, especially in a younger, say, patient who's going to lift heavy weights, manual laborers and all that. So Sovek Kapanji is not totally complaint-free also. So as long as possible, we would avoid that. And if still there is definite cartilage loss, there is definite features of arthritis, go for the arthrodesis, arthrodesis and proximal pseudarthrosis.
So my question was that would you rely on development of arthritis or any time duration, that post-injury duration is like that?
I wouldn't, put a definite timeline on this, but it is our clinical examination, radiological examination, and
you can go for MRI or CT. So do you go for MRI or CT?
Yeah, I mean, if necessary, we can always do that. We can go for those. If you're in doubt how the cartilage is, or if you're in doubt how the sigmoid notch is, the ulnar head is, you can do either MRI or a CT, definitely. If there is a difficulty in making that decision of trying to do a conservative procedure or the arthrodesis.
Sir, does the compression test help in that?
Yes, the compression test does help. Compression and rotation, you get the crepitus, which generally points to a
arthritic failures.
But again, there is one thing. If it is an incongruity, again, you might get a crepitus. So early stage incongruity may not have resulted in a cartilage loss. So there have been a number of people, especially in literature, they say how you do a sigmoid notch osteotomy, sigmoid plasty, notch plasty, and all that. So you can try those techniques if you think the cartilage is intact. In an earlier patient who comes early.
I had opportunity to reconstruct DRUJ, which was nearly 6-year-olds, and I was curious to see her DRUJ. And there was no much cartilage loss was there. So after such a long time, also arthritis doesn't develop. So
I think I saw this presentation of yours in ISS. Did you show this case sometime back? Anyway, okay. Yeah, the thing about arthritis not developing is if it's not a joint, if it's actually far away, if it is subluxed, all that, there is no contact for the cartilage to wear, and in those situations when you bring it back, it might still work. So it may have been like that. I'm just assuming that that was the case.
Anyone wants to comment or ask questions? Okay, then my last question is, sir, throw some light about DRUJ dislocations. It is quite troublesome. How you approach, when to reduce. Reduction is not a question. We need to reduce it. Some other some technical tips.
So the dislocations, if it is not associated with any bony injuries,
yes,
you open the DRUJ and you identify or locate the reason for the dislocation, which is it's not allowing it to go back. As I mentioned, usually ECU tendon is the main factor that prevents a relocation of the joint. So you go search for the ECU tendon, and sometimes you also see the TFCC and the capsule interposed. So you have to do an open reduction. We always approach it dorsally first, and then look for these tendon in position and reduce it, and then reconstruct the soft tissues there and pin it for a short time. And so it's not uncommon, especially if you look carefully, these dislocations, patients with very painful wrists, you must do the supination pronation to avoid missing out a dislocated DRUJ. So again, it requires surgery.
Yes, means issue interposition, as you told, no. But main fear that if you will release the issue, you need to injure the subsheath of
The
issue.
subsheath, subsheath. It is easier said than done, because in these kind of injuries, the subsheath is very, very, finding it and again, repairing it is difficult. But yes, that is the idea. You have to, otherwise the ECU will tend to sublux again.
So I think we'll discuss further. Meanwhile, I would invite our second speaker, Dr. Amit Varade, to present his cases and technique of arthroscopic TFCC repair.
Yeah, thank you. I would like to thank Dr. Amit Vyas and ROSA office bearer for giving this opportunity. And I would like to also thank Binu Thomas sir for a very comprehensive lecture, right from X-ray up to the joint arthroplasty of DRUJ. So very briefly, I will present interesting 3 cases. I'll share my screen. So are you able to see my screen now?
Yes, we are able to see.
Thank you. So this young gentleman, he presented with ulnar sided wrist pain since 2 months, and before 2 months he had fallen outstretched hand, and due to the ulnar sided wrist pain, he was not able to do activities with his right hand. He was not able to lift the heavy weight, and if you see the MR image, we can see that there is avulsion of the TFCC. So this is the tabletop test which Binu sir has mentioned. Here, patient is pressing his palm on the table by keeping elbow straight, and we can see prominence of the ulnar head, and which suggests DRUJ instability. So in such cases, wrist arthroscopy is gold standard, because with the help of 3-4 portal and 6-hour portal, we get an excellent view of TFCC. So the important advantage of arthroscopy is that we can see the ulnocarpal joint nicely. We can see everything. We can see TFCC tear, whether it is a radial tear, whether it is a peripheral tear, or whether it is a dorsal tear, and if there is an avulsion from the fovea. Everything we can make out with the arthroscopy, because this is very important for doing further procedure. Means if there is avulsion, we can reinsert it. If there is central tear of the TFCC, then we can just debride it. And peripheral tear, we can repair it. So regard this patient, we did arthroscopy. So before starting, we did this ballotment between radius and ulnar head, and it was quite unstable. So on arthroscopy, we found that he was having avulsion of, this is the TFCC, and this is the hook test. And hook test means there is we can lift, we are able to lift the TFCC, and there is loss of tampolin effect. Both the signs suggest that patient is having TFCC injury, and this is the cause of instability of the distal radioulnar joint. So we repaired it. So this is after repairing. So now tampolin effect has came back and hook test is negative. So this is the repair which we have done by using 20 PDS suture. So in this case, we did perifoveal type of repair. So after the repair, the DRUJ become very stable. And post-operatively, we have given him 6 weeks immobilization in above elbow plaster slab. We give generally immobilization in mid position between pronation and supination. And after that, we start gentle mobilization for 1 week, of course, of pronation supination, and then aggressive mobilization. So this was a recently done case. So anybody want to ask on this case, or shall I go for next case?
I want to ask about the type of immobilization as you informed.
Immobilization is above elbow plaster slab in mid position between pronation and supination, and fingers free and thumb free for 6 weeks.
Do you prefer full supination or mid prone?
Mid position, yeah. I have heard a lot of speakers, lot of senior surgeons immobilizing in mid supine, a bit of supination, but we do it in mid position.
Amit, one question. So how do you, this was you anchored it to the capsule, is it?
Yeah, it is, sir, perifoveal type of repair where we do it on both sides of the ulna, on volar side also and dorsal side also. Actually, in the video, we are seeing only one part. From the another side also, there was a knot. So actually, we took 2 or 3 knots on one side and 2 or 3 knots on the another side. Okay. So it is a very strong repair.
Okay, very good.
And it saves a lot of time as compared to transosseous type.
Very good case.
Yeah. Thank you, sir. Another second case. So as Binu sir was mentioning about this procedure. So this 26-year-old student, he had pain on ulnar side of the wrist joint, and he was not able to lift heavy weight. And he was having trauma and ulnar styloid fracture before 4 years. And on X-ray, we can see very well that there are remnant of the ulnar styloid. Most of the ulnar styloid was resolved. And here we can see subluxation of the DRUJ. So this was the clinical picture. We can see the click on pronation and supination. And preoperatively, his grip strength was also reduced. So the questions which come in our mind, so do we need to fix all ulnar styloid fractures? And can we do surgery for TFCC in such neglected DRUJ subluxations? So regarding the first question, ulnar styloid fractures, basically when there is fracture from the base of the ulnar styloid, there are a lot of chances that TFCC might be avulsed along with the ulnar styloid. So this needs fixation. And if there is a type 1 and type 2, means tip and mid portion of the ulnar styloid fracture is there, then we do not have to fix it most of the times. But clinically, we have to see the instability also. Then regarding the second question, can we do surgery for TFCC in such neglected DRUJ subluxations? See, this case, this patient was having this problem since 4 years. And in 4 years, most of the TFCC has been fibrosed. And so no point in repairing it. So now in such cases, what we do, we reconstruct it with this procedure, Adam Berger procedure. In this here, this is the palmaris longus graft, which we have used for reconstruction. So this is the distal radioulnar joint, and we can see this is the hole which we have made into the distal radius on the sigmoid notch side. So this is how we do this, and I'll show in next slide. So after passing the palmaris longus, reconstructing dorsal and volar ligament, both the ends of the palmaris longus come out on ulnar side, and here we have passed both the tendon ends through this tunnel made in the ulna. So here, so basically it is like reconstruction of the dorsal and volar ligament and inserting it on the in the fovea. So that idea is to make the DRUJ stable. And so these are the 3-month follow-up of this patient. Full range pronation supination and flexion extension. And see, this before surgery he was having this click, and now after surgery it has gone. And now he is able to lift the weight and no pain. Okay, so this was the second case.
Yes, Amit, can I ask a question now?
Yes, sir. Yes.
What size of drill you use for the palmaris? Is this a palmaris longest graft?
Yes, sir.
So which size drill you use?
Acha. So
Drill diameter.
So there are we have to make 2 tunnels, one in the radius and one in the ulna. So tunnel in the radius, through the tunnel of in the radius, we need to pass the graft only once. Means only single one diameter of the palmaris longus. And in the ulnar tunnel, we need to pass both the ends of the palmaris longus. So the tunnel of the ulna should be bigger than the tunnel of the radius. That is one. Second, there is no fixed size of the drill hole size. So we need to decide it on table depending on the size of the or diameter of the palmaris longus of the patient. It varies.
Roughly 3 mm or 4 mm?
No. Roughly we can say it is like 2.8 or 3 mm. And we have to be very careful while doing drilling in the ulnar tunnel, because there are a lot of chances of fracturing it.
So the problem is with the ulnar tunnel, because the ulnar tunnel is bigger one. So there are sometimes the walls breaks away.
Yes, sir. So if we are not able to pass both the ends of the palmaris longus, then we can trim it also.
Okay.
But
don't make bigger tunnel.
One comment I like to make. I mean, it's safer to use a cannulated drill bit.
Yeah.
So that you first put a KY through, then you know that you're unlikely to fracture the ulna, or even the radius also, so that you're staying away from the sigmoid notch.
Yes, sir.
So usually 3.5 mm
should be enough.
Yeah, it's enough.
So now there are some people are advocating using anchor also in the ulna. Or we can say if length is sufficient, we can just suture it. What do you do, sir? You use anchor or you just suture the graft?
I just suture the graft.
Okay.
But now Arthrex has come out with very fancy, toys which are very nice. The push lock and all that, you can use it. They are very good. The push lock, you can use it outside to anchor the tendons together.
Okay.
Can we use true hole in the ulna? 2 holes.
In the ulna?
Ulna. Separate holes for 2 ends. So
you have to do it without breaking the bridge.
It's difficult. Basically, we need to put it in the fovea. So both the ends should go in fovea. Only one tunnel. So that was the second case, and quickly I will show third case. So this 29-year-old gentleman, he had acute injury and fall before 4 days. And he was also having pain on pronation and supination. And X-ray, we can classically see the increased distal radioulnar joint distance and dislocation rather on the dorsal side. So this was MRI images showing TFCC avulsion type of injuries. And clinically, just see, we have to check, as sir said, we always check it in pronation and supination. So it was all unstable. This is Ballotman test. So is there any conservative role of conservative treatment in such patients? So definitely no. We need to stabilize the DRUJ. And how to if there is avulsion of the TFCC, how to reinsert it, that we will see. And can patient will get back range of movement, particularly pronation and supination. We will see this. So this patient, we have opened it from the dorsal approach, opened the fifth extensor compartment. And once we open the fifth extensor compartment, we can see this. This is the ulnar head and this is the TFCC. And this was the avulsion. I have a nice video also. So this. So this is the head of the ulna, which is unstable. This is the TFCC, which was avulsed from the fovea. This is ECU tendon. And we have to reduce the ulnar head. And I am pointing towards the fovea. Reduce it and just we have to put this TFCC in the fovea. So in such cases, anchor is very helpful. So this is a 2 mm anchor, which we have used over here in the fovea. And this is the anchor. Here anchor is placed in the fovea, and these are the needles. And with these needles and suture fiber wire, we have repaired the TFCC and inserted into the fovea. And this is the 2-month follow-up. He got reasonably good range of movement except terminal 10-degree supination. Thank you. This was the third case. So, if anybody wants to ask.
Do you do anything for dorsal capsule?
No, nothing was done in this case. It was just, in this case, I have just reinserted the TFCC.
We can augment the dorsal capsule by, the Ravi Gupta's technique of extensor retinaculum. Part of it we can be taken and, use it to augment it if needed. That's an option. But I think I don't think you needed it for this case. What was the reason for the dislocation, Amit? Was there any interposed tendon?
Yes, sir. There was an interposed extensor tendon.
Which you removed. Okay.
Extensor tendons, yes.
Yep.
I forgot to mention. I removed it intraoperatively.
Okay. Yeah, that's usually the case.
In most of the time when DRUJ is dislocated, it is the forearm is fixed in either mid-prone or pronation. If it is subluxating, means instability is there, then pronosupination will be intact. Is the same experience or I am wrong somewhere?
Yeah, right. Yeah, I mean that is a red flag. This fixed, no supination, no pronation in an acute injury. That's a red flag for surgery.
Okay. Okay. Shall I stop sharing, Amit?
Yes, please.
Thank you.
So I think very nice cases. and with different problems encountered in day-to-day practice. Thank you, Amit.
Thank you.
So I would like to invite our ROSA faculty, Dr. Deepak Jain, sir, to share his screen and present a case.
Is it visible?
Yes, it's visible, sir.
Okay. I'm just presenting as case in just 2-3 slides. So that's I don't have the good quality X-ray, but that's lateral view is showing the dislocation of the distal radioulnar joint. So patient is 44-year-old male, history of road traffic accident. He is hypertensive, and he had fracture of the proximal tibia on right side also, same side. So Dr. Amit, would you like to take on from here? What can be done for this patient?
So what information I got that it's acute injury and distal radioulnar joint is dislocated.
Yeah.
Is any movement are there? Means
It's reducible. It's
okay, it's reducible, no?
Yeah.
So I would like to see what is the cause of this reducible dislocation. Most probably there may be avulsion of the TFCC. I have not missed anything. Means there is no radius fracture, no, sir?
No fracture.
Yeah. And how old it is?
Just 1 day.
Okay, 1 day.
Yeah.
Binu sir, do you have different opinion?
Regarding?
Regarding this management of this case?
So, you're thinking about operation or conservative? I mean,
So that's a question. How to proceed? How to manage this case? What investigations to be done, and what surgical or conservative treatment can be done?
Yeah, this is an acute TFCC injury with a dislocation, but we can reduce it, no? So
Yes.
this is where it becomes a little gray. Do we immediately operate? Because if you keep it in supination, it probably is reduced. Am I right?
It was not stable. It was getting
unstable.
reduced, but yeah.
Then you have the option of fixing it. I think there would be no ambiguity in that. If it's unstable, and then even if you keep it for 6 weeks, and then at the end of it, again see the same instability, you would be wasting the patient's time. So here it's a frank dislocation and unstable. So I would go for surgery acutely also.
And what can be done to fix
these acute injuries? Question is, should we go for an arthroscopic fixation or an open fixation? Since there is no doubt about the diagnosis, and an MRI may help to know whether there is a foveal avulsion or is it where the injury is. That is what, if you find it is a foveal avulsion, and then there are excellent techniques either way. Whatever you are comfortable with, if you're comfortable with like Amit showed, the arthroscopic repair, go for it. Otherwise, I have found that the Vellore approach to these for foveal avulsions, it's quite simple. So I would have no hesitation in doing either arthroscopic or open also. But right now, preferably, we will go for more in favor of an arthroscopic fixation rather than open primarily. If it's a foveal, but that's what the MRI is going to suggest, whether it's a foveal avulsion or not.
Yes.
You look at, I mean, think of the PAMA classification, and that's
Sir, my question is that if suppose foveal avulsion is there, then how you will go arthroscopically to fix it with the fovea?
the same. I mean, I do a little differently from what Amit has shown. We put two KYs through the ulna, coming out through the fovea and into the triangular TFC. There, then we use these loops. We use ethylon, just loop pass through the needles. There are two needles that's on either side of the styloid. There are these, so two needles. We pass these loops, and we can actually use a grasper and pull out these loops outside. Then we put a fiber wire through that on both the loops, and then pull it back and tie it onto the ulna. That is what we generally do. It's not that difficult as it may seem. Putting those folds, it is reasonably okay to do it. If it's a peripheral tear, of course, capsular repair is good. And but we have also open repair is not a no-no actually. You know. And the open repair, I prefer the volar approach now rather than the dorsal approach. Because I feel that we are producing more instability through by opening out all these retinacula and all that.
Sir, it is quite interesting, and I would like to get some, if you have video or something, anytime.
Okay, there's a very good paper that is describes the whole procedure very well. So I'll share some videos.
Sir, my question is the dislocation is dorsal, and you want to approach to the volar. So, what's your opinion on that?
The TFC,
Since the dislocation is dorsal, so their pathology should be on the dorsal. Vent should be on the dorsal side. So we will have to approach to the dorsal only.
Not necessarily, no. It can still be the wall. You can still find that the volar ligaments are injured. So, you know, it does not need that. Need to be. That's the MRIs will give you a good idea again. So, for what I'm saying is, a volar approach, you write on the fovea. That was the contention.
Yes, sir.
So, Dr. Deepak,
yeah, that patient was because he had fractured tibia also. So, an emergency was taken, and just 2 K-wires were used to stabilize close reduction. So, any comments on this? Maybe further we investigate, or we wait for some time and move the K-wire.
It still looks dislocated, you know, Deepak. It looks dislocated still.
Yeah. Probably we need either CT or MRI to.
But that view is also not proper.
Yeah.
It is oblique view.
Oblique
it's not
view.
exactly lateral view.
Lateral view is not true lateral. How to proceed now? We do CT, or we wait for some time and then remove the K-wire and assess the stability?
So you have already pinned it now.
Yeah.
And if you have any concerns about your reduction, then I think, you know, you may have to look at whether
So
further.
on the SCM views, it was looking reduced. The true
Reduced.
view.
Okay,
Yeah.
then since you have decided and patient has other injuries, wait for 6 weeks, see if it is stable. If it is not, then again prime him up for surgery.
So then we go for MRI and
MRI, yes.
Yeah. Yes. So my question is, in emergency, should we do this kind of K-wiring or just put plaster and assess properly, and then go for the MRI, CT, and then finally decide what is to be done?
Yeah, that's a very good question. Patient is being taken up for another fracture fixation. You are in theater.
Yes,
I
sir.
suppose there is no, you know, it is okay to put a K-wire and stabilize.
It was grossly unstable, so
Yes. Yeah, but you have to keep your fingers crossed whether it will. That's enough.
yes.
Any further discussion about this, or sir?
So this is a situation, in an acute situation. Do we go for repair or do we try conservative? And then I work with people who are very good wrist surgeons, and they always tried conservative management. But at the same time, if you are the patient, do you want to wait for that 6 weeks and be told that, sorry, this didn't heal, so now we'll have to do another procedure. So this is where the decision have to be taken. It's frankly unstable, as you said, and then anyway you need to have surgery. You know that it's not going to heal. Then there is a point in trying to find out where exactly is the lesion and do the appropriate surgery immediately. Immediately in the sense with plan.
Yeah.
Yeah, I think I also feel the same. What I personally feel, if we are doing anything in acute scenario, acute means in first 7 days, then it is very easy to do it, and it is very easy to repair it, whatever the things are there. If we wait for 6 weeks now, then there are two problems. One problem of stiffness, then problem of this instability, like these tissues are not that good. So I think it has to be done in acute scenario, like in first week after stabilizing the fracture.
Yes. I would
Yes, I
also.
think with the discussion we got that both ways are okay. If you don't have such expertise or then as Binu sir informed that you can reduce and wait up to that time the other fractures are managed, then it can be evaluated. And if you have expertise, then you can directly go
for fixation.
Quite good.
Amit, I want to comment one thing.
Yes.
If the dislocation is dorsal one, then it should always be immobilized in supination. That is very important. Number one. And second, if it is reducible, then there are chances of good healing. If major injury is not there, then you can take a chance by putting in full supination with complete for the reduction of the joint. That is mandatory. Sometimes it works.
Yes, sir. Very nice point.
Yes, that immobilizing and supination, I think, is mandatory there.
Yes.
That's the only way to reduce the
dorsal dislocation.
Sir, in your wide experience, Binu sir, have you seen volar dislocation?
Volar dislocation, I've not clinically come across. Even in literature, the numbers are very, very
10%.
few. Yes.
Incidence is 10%.
Yeah. Yes. I mean, in a Patients that come later, you have this multi-directional instability kind of thing. But in an acute situation, it is, in my experience, it has always been dorsal.
So I will share one another case. I think my slide is visible.
Yes.
So this 32-year-old male, right hand dominant, he's property dealer by occupation. He had forearm bone fracture on the left side, which was left side, which was fixed with the nail 3 years ago. Now he presented to me with inability to extend the thumb and supination of forearm. So this was the wrist range of movement. He has restricted supination, although pronation was okay. And you can see he's not able to extend his thumb. And you can see the prominence of ulna. And his radius was fixed with the nail, and he has dislocated DRUJ. So now there are two problems. One is the inability to extend the thumb, and second one is the DRUJ, which is 3 years old. So I would like to ask Binu sir about his thought to how to manage this type of.
The thumb extension, probably, I think the implant would have injured the EPL there, and that must be the reason. So you have to get the implant out and do a standard EI to EPL transfer when you're operating. The other thing is, I would get a CT with a 3D reconstruction, because the primary reduction of the distal radius may not be adequate. So that is why this has happened. So we would like to assess that properly. And here, there's nothing in the ulna that is probably a primary pathology. The pathology is in the radius. So your correction can be addressed at the radius, corrective osteotomy, and see if that helps with the relocation of the DRUJ. But again, what is a cartilage like this at that joint? It will be difficult to say at this point. But we will. I would try to actually correct the radius and see if the ulna falls in place here primarily before planning for any stabilization.
Yes, agree, sir. So
at six years, how or what is the status of TFCC we consider in this?
Yeah, it's 3 years, but yeah, really.
I've showed a 10-year-old patient. 10-year history that patient had where the distal radius was malunited. We did it, and he had very good movement. So I would still consider that it may be okay to bring the radius back in place. If there is a problem at that point, we can address it. Like, if it's still unstable and if the ulna is anatomically, your joints are back in place, and if there is still subluxations, you can go for a Bryan Adams or any of those reconstructive procedures. Rather than, here, what are the other options? So Kapanji, before you go for that procedure, you can try to give him he's a young patient, isn't it?
Yeah, young patient, sir.
Yes. So you should try to provide him with a good functional forearm and wrist.
Yes. So I would like to
Can
ask,
we do, sir? Can we do ulnar shortening in this case, sir?
Even ulnar shortening is not going to bring the joint back. No, it is still there's a widening here. So what basically I feel is that it is the radius that has deformed. So by correcting the radius, the joint may fall back in position. What's the function? We'll have to assess and see, rather than primarily thinking of a salvage procedure. That is all.
yes. So I would like to ask two questions from the faculty. First one is that suppose how to prevent this type of problems, because these Galeazzi fractures are quite common. And second thing, if suppose after correcting the radius, still your DRUJ is unstable, is it possible to get this situation, and how we will deal it? Binu, sir, or some...
Okay. Yeah, I mean, this fixation is actually, if I am critiquing it, it is inadequate, basically, in the sense, we would definitely go for a plate fixation in these situations. Provide a stable anatomical reduction. Now, intramedullary nail is just like a wiper effect. It will just move like that, isn't it? So that's probably what happened also. And so primarily anatomical reduction and stable fixation. So that should address, as Galeazzi should go, the chances that a good stable reduction and fixation will make the DRUJ stable is good. Now, in spite of a good reduction and the proper reduction and fixation, if it is still unstable, what is generally practiced is you stabilize the put two KYs through the radius and ulna and reduce it and keep it in acute setting I'm talking about. So then if it is still at the end of 6 weeks, you remove the wire and see how the stability is, which is the common practice that is we are all doing. So if it is, most of the time it will be stable and the patients will have no problems. But rarely, if it is unstable, then you'll have to address the distal radioulnar joint.
I also agree with Binu, sir, because in Galeazzi situation, most of the time, when you fix radius and get the adequate length, then there are always chances of DRUJ relocated. There is minimum possibility of getting these problems. But if you still feel that there is instability, then you can temporarily fix it and the outcome is going to be good.
Now, suppose you have an arthroscope in theater and you are good at it and you want to do it, I suppose what prevents you from fixing arthroscopically also?
Yes.
So what is common practice is we put KYs, but scopic reduction is also, there has been in literature reports of how they looked at the arthroscopically, found the TFCC ruptured and put a repair. Has been also done. So it is also an option provided your scopy skills are good. It is available right there also. as I said, common practice is KY. Stabilize it and wait for 6 weeks. If it heals, that is it.
And second question for the junior colleagues, how to prevent it? Means because radius has a special curvature. So while fixing, what things to be taken care?
Galeazzi is always an anatomical, this forearm bones has to be reduced anatomically. It is a dictum, and if Galeazzi is there, it has to be anatomically reduced. You have to get the anatomical length of the radius to get the proper bow and good joint. That is the prerequisite for Galeazzi's fixation.
Yes.
This probably is a compromising type of an injury,
Yes.
which cannot be fixed by an intermedullary implant.
Yes.
I think.
Yeah, both curves should be maintained.
Yes.
I think all are agree that we should we should remove the implant and try to get the length of the radius. But as I asked previously also that because it was 3 years old and I was spectacular about giving him the doing this because he was functionally well, and although he was young, but he is not engaged in very heavy activities, and his left side was involved. So, and he didn't want multiple surgery. So what I did, I removed the implant and then
EPL reconstruction.
yeah, EPL reconstruction was done. Sorry, it is not moving. Yeah, and did the Suwek Kapanji procedure. And somehow he worked well up to 2 years follow-up. He regained the supination, and his EPL was also doing well. So, any critical comments?
I mean, I cannot find any fault with your management, especially if the patient has done well.
Yes.
Yes. You know, again, see, you're doing a salvage procedure, which is done if a reconstruction of the anatomical reconstruction is not possible. So that is all. But with discussion with the patients who says, no, I don't want to, I'm not sure that I will subject myself to a second procedure if the first one doesn't work well and all that, then I think this is a good surgery you've done, and the results also show that. Yes.
Yes. Anyone wants to comment on this or add some things in discussion? Amit, Varade, Saini boss.
No, this result is quite well, and I think it is okay.
The final judge is the patient, so he has found you.
Finally, it is the patient to decide what he wants.
Yes.
So, I think we have overshooted the time. Now I will hand over to ROSA official, Dr. Jaswant Singh, sir.
Hello, thank you. Hello, Amit. Yes. Can you hear?
Vice President ROSA. So, sir, I will hand over to you for the conclusive remarks. And Well,
So we had a very nice talk today, and I'm thankful to Professor Thomas sir and Dr. Amit for a very painstaking talk by Dr. Thomas and a very good some papers from the Amit Varade and some good cases. On behalf of Roja, I'm thankful to you. Beside that, I'm thankful to Amit, you also, the Saini sir, and Madam, Madam Party Madam. And basically, this talk and hand surgery meetings regular is the brainchild of her. And because of her only and her motivation, we are here almost monthly meeting we have. And to my surprise, we had 3,000 of listeners today, and that's a wonderful achievement. And as a concluding remark on the DRUJ, I'll just say many of these cases of DRUJ pain, they subside over the period of time. And if still the pain persists, then we must try to restore the anatomy. And all these salvage procedures are for the last resort. It's just like a girdle stone procedures. Though they are helpful, they give a good results. But the primarily we must try to restore the anatomy. And I would also like, before concluding that, I would also like Madam to comment upon this talk. What's your take on this? Madam, can you hear me?
Yes, I can hear you.
Yeah.
I mean, there's so much learning that we are still doing. All these talks are really very enlightening, and we get to hear the best of the people thanks to this Zoom business. And otherwise, where would we have a chance to hear Dr. Binu Thomas and things? So I think it's a very good thing that we've started.
Thank you, ma'am.
Thank you, ma'am.
Yeah.
Beside all the faculties, I am also thankful to all the Roja faculties, Dr. Soni, Dr. Vijay, and many more. Dr. Saini is here, and all the all the Roja members, all the listeners of this OrthoTV, and so thank you all. Good night.
Good night, sir.
Good night.
thank you. Thank you.
Bye.
Thank you all.
Bye. Thanks a lot.
Bye.
Thank you, sir. Thank you, Jaswant.
Thank you.